Minister Ong Ye Kung.
Mr. Speaker, sir, 1,711. This is the number of people in Singapore who had died of COVID-19 infections as of 31st December 2022 and as reported in the White Paper. MOH estimated an additional 2,000 deaths over the course of the pandemic that is above the expected number of deaths based on pre-pandemic trends. These individuals not recorded in the official death toll for COVID, but they might have died of undiagnosed COVID-19 infections, or COVID-19 could have worsened some underlying conditions leading to their deaths. All in, over 3,700 deaths estimated. Most of them older with comorbidities, underlying illnesses, many unvaccinated, and they are most affected by COVID-19 infections. We will never know the exact number or all the names and the faces of every victim of this pandemic crisis. Thank you. Never had Singapore gone through a crisis that inflicted such a heavy toll on the lives of our fellow men and women. Since independence, I think nothing even comes close. This is indeed a crisis of a generation. And behind every passing, there were family members, loved ones, doctors, healthcare workers, doing their best to comfort them, to save them. At MOH, and I'm sure in this House, we mourn their deaths and extend our deepest condolences to their families. COVID-19 placed lives and livelihoods in a very stark contrast, or maybe more aptly put, it put in contrast your desire to survive and live versus what's the purpose of living. This same challenge was faced by every country, every region, which is how do you navigate out of this dangerous conundrum, regain your normal lives while protecting the lives of your people as much as possible. Every country and region faced this challenge, and everyone took their own or its own path, some by choice, others forced by circumstances. And I would say how each country or region fared in this COVID-19 common challenge essentially boils down to the following three judgment calls. First, whether through your decisions and in the early stages of the pandemic, we effectively make hospitals the singular defense against the virus. And here, past experiences matter. Many countries in Europe or Western Hemisphere, Americas, deal routinely with influenza, including very severe winter seasons. The influenza playbook, they used that, and it was proven to be inadequate for COVID-19. So the virus spread widely. Hospitals effectively became their singular defense, which became overwhelmed, leading to many deaths. On the other hand, places like Singapore, South Korea, China, we had seen ghosts before. We've seen SARS and MERS. We had the processes and capabilities in place, and then we moved quickly to contain our initial outbreaks with stringent border measures, testing and isolation of cases, tracing and quarantining of individuals. And so we used our entire public health arsenal. And we succeeded in preventing our hospitals from being overwhelmed in the initial stages, especially in the initial stages of the pandemic, before there were vaccinations. If there was one thing the Prime Minister constantly reminded the MTF chair, it was this golden instruction: protect our hospital capacity, and we took it all very seriously. Because when the entire weight of the country's health rests on hospitals, even if that was not the intention, it will not just be COVID-19 patients that die, but everyone who need urgent medical attention can die. In many countries, this was what happened. Doctors have to turn away patients who are very ill, and they were all just waiting along the corridors. And when a hospital bed or ventilator becomes available, the doctor have the heart-wrenching task of deciding, who do I save? This judgment call, the careful husbandry of our hospital beds before the great majority of our population was vaccinated, is the primary reason why Singapore kept our COVID-19 mortality rate low. Second judgment call has to do with vaccination coverage. Most countries, they roll out vaccines, national vaccination program, and then they achieved varying levels of coverage and then resilience. Those were, if you remember, were confusing times because the vaccines were new and anti-vaxxers, they were out in full force, spreading falsehoods and half-truths to persuade people to avoid vaccinations. I know of friends who do not want to take the vaccines, but I think it's one thing to have a personal preference and quite a different thing to make it into a public campaign because that affects other lives. I had to exercise my authority under POFMA when I judged that a circulating falsehood was misleading people into avoiding vaccines. The law was designed for such occasions, especially when lives are at stake. It is worth stating in this House again that the weight of global evidence clearly shows that COVID-19 vaccines are effective and safe. Our latest MOH data shows that during the Omicron waves of 2022, vaccines lowered the probability of severe disease and deaths for the elderly by more than 5 times. Do COVID-19 vaccinations have side effects? Definitely they do. Dr. Lim Wee Kiat, my colleague, always say, if a medicine has effect, it can have side effects. Yeah. If you have a medicine without side effects, have no effect. Yeah. We were clear and transparent and published the incidence of side effects every quarter. The incidence of severe adverse effects for the vaccines has been low, typically 5 to 7 per 100,000, and great majority recover on their own without even going to hospitals. So the benefits far outweighs the risk. Fortunately, the great majority of Singaporeans and the public trusted our recommendations to take the vaccines. We achieved over 90% vaccine coverage. And I thank the Workers' Party for supporting this very pivotal national effort to vaccinate our population. This is our collective judgment as a people to achieve high vaccination coverage. And this is the other big reason why we could minimize the number of deaths due to COVID-19. Then came the third judgment call, a tricky one, which is having achieved high population immunity, when should we open up? For many countries in Europe and America, after the virus has spread widely with many people infected and many deaths, their population immunity was actually high, and they could afford to open up early. So in the course of the pandemic, many people also urged MOH, MTF, can you quickly open up like other countries in the West, in Europe, in the Western Hemisphere? The desire is understandable, but they overlook the key difference between us and them. They paid the price in human lives, which we refused to pay. We, along with a small handful of countries, we managed the situation tightly, contained the spread of the virus, and used the time to vaccinate as many people as possible. Then came a time to open up, and you have to switch from one set of rules to another. You have to switch playbook from Queen to Beatles. From a COVID-0 policy to something closer to managing a bad influenza season. And this was a major psychological leap for doctors, for MOH, and for society. Countries adopted different timetables to this reopening. I think Australia probably went first. They took the first step, followed by Singapore, and China only recently opened up. And looking back, in all three decisive moments of judgment, I think we collectively made the right calls. Despite this, COVID-19 has been a humbling experience. We have a duty to learn from the crisis and ensure that those whose lives were lost to COVID-19 did not pass in vain, and it will not be in vain. We have translated the trials and tribulations of the pandemic into 6 areas of improvements to better prepare Singapore for the next pandemic. So for the rest of my speech, I will go through each of this area. The white paper have mentioned them briefly, but I will elaborate. First, we will strengthen our hospital capacity. Our healthcare system was severely tested during the pandemic. At one point, we were monitoring bed availability, capacity, caseloads almost by the hour to detect any signs of imminent collapse. Fortunately, we had the SMMs, safe management measures, in place. We had high coverage of vaccinations, which protected our hospitals. At that time, many questions were asked, including in this House, why didn't we plan for more hospital capacity in anticipation of the pandemic crisis? If we did, at that time, I was asked, if we did, we could have relaxed the SMMs. This would not be a realistic course of action. To illustrate, even with vaccinations and SMMs, at the peak of the Delta wave 2021, we had almost 1,300 patients hospitalized, 140 in ICU. If we had relaxed the SMMs, the number, I think, easily doubled, probably tripled. So this is equivalent to 3 or 4 full general hospitals set aside as spare capacity during peacetime, waiting for a surge and then be deployed. So it's just not realistic to set aside so much spare capacity. So we should not size the healthcare system to take on the full brunt of the next pandemic. This pandemic has taught us that true resilience must not come from just adequate infrastructure, but also from our social resilience, our collective behavior. That said, with delays in our infrastructure development due to COVID-19 and rising hospital workload post-crisis, our healthcare system today is less resilient than ideal. Dr. Wan Rizal, Mr. Gerald Giang raised concerns in this area, which I agree with, especially the stress that is giving healthcare workers. Our public hospital bed occupancy has risen from pre-COVID level of 87.6% in 2019 to 93.1% in 2022. It's gone up by almost 6 percentage points. This is largely driven by patients staying longer in hospitals, from an average of 6.1 days in 2019 to 7 days in 2022. So that increase alone explains for all the increases in occupancy. And why is that so? Because we are seeing more older patients with complex conditions, and they need to stay longer in hospitals. So the percentage of senior patients aged 65 and above has risen from 39% in 2019 to now 43%. That's 2022. Many of them are frail and with comorbidities. And we also found an increasing number being hospitalized because of other viral infections, not COVID, but other viral infections, respiratory illnesses, including pneumonia. We cannot rule out that this could be after effects of being infected with COVID-19 for some, or it could be a rebound of other forms of infections post-crisis. And during the crisis, suppressed. Once masks are removed, we go back to DORSCON green, they rebounded. It may also simply be a result of our population aging very rapidly. As I've explained to this House, MOH is doing many things to address this. I will not repeat them today. And this includes the recent announcement to strongly protect our healthcare workers against abuse and harassment. However, a post-crisis initiative, which I have yet to explain, are the TCFs, the Transitional Care Facilities. TCFs, they are for medically stable patients from public hospitals waiting for long-term care arrangements, such as going to a nursing home or going for home care. During the pandemic, we set up 500 TCF beds across 5 sites operated by 5 private sector healthcare providers. And the TCFs have proven to be very useful. They are very well utilized, and it is as good as adding 500 more beds to our acute hospitals. We have therefore decided that TCFs will become a medium or even long-term feature of our healthcare system. We will retain the current facilities, including continuing to use Changi Expo Hall 9 primarily as a TCF with about 200 beds there. And I thank MTI for sacrificing some exhibition space for MOH. And today we do not have a TCF in the West, and we will start one there in the next few months in close proximity to the Ng Teng Fong General Hospital. We will also continue to expand the community and step-down care sector, such as community hospitals and nursing homes. Now let me move to the second area of improvement, which is we will boost our pandemic preparedness and response. This means having the capability to quickly understand what is this virus or pathogen we are dealing with, and then what actions to take. When dealing with any infectious disease, we generally need to understand 6 key characteristics in order to formulate the right response. COVID-19 really helped us boil down to these 6 important characteristics. How it spreads, for example, between persons in close proximity, or is it airborne through aerosol? 2, the length of its incubation and infection periods. 3, R, or reproduction number, which is a measure of its infectiousness. 4, how deadly it is. 5, who are the vulnerable groups? Who are the vulnerable groups? For example, is it seniors, children, or both? Spanish flu, for example, affects young children especially. And 6, how to treat and prevent it. Without good answers to these 6 basic questions, we will be fighting in the dark and most likely end up fighting the last war. As Dr. Tan Wu Meng and Mr. Yip Hon Wing have pointed out, we need strong public health, scientific, and research capabilities to quickly assess these key characteristics. And that is the objective of PREPARE. It stands for the Program for Research in Epidemic Preparedness and Response that I launched in November last year. And this is our national epidemic R&D plan and a major initiative arising from the crisis. It will also strengthen our international pandemic research partnership to build a network of partners and allies to play our part in strengthening global surveillance of emerging pathogens. We will leverage GIZ. GIZ played an instrumental role during the COVID-19 pandemic. It is a global non-profit platform for open sharing of genomic data of viral pathogens, and today is the world's largest repository of SARS-CoV-2 sequences. Singapore will work closely with GIZ, and they have established a base here in collaboration with A*STAR. After we understand the characteristics of a dangerous pathogen, what do we do with the information? Having gone through SARS, H1N1, and the various phases of COVID-19, we have developed a range of responses. The characteristics of the pathogen will determine our response. DPM Wong, yesterday, he mentioned this briefly in his opening speech, but let me elaborate a little. Mr. Speaker, sir, can I show a chart on the screen, please?
Please do.
Not this one. Okay. Okay, yep. We can plot pathogens on a graph. In this chart, The horizontal axis measures transmissibility. Yes, we can freeze there. And the vertical axis measures severity. It is a simplified way of measuring the 6 characteristics that I spoke about. So if you notice at the top right-hand corner that looks like a durian or explosion, that is disease X, the disaster that we dread. But the pathogen has high transmissibility and high severity, and is deadly. And if you move to the left, you notice the red dot, that's SARS, with high mortality but low transmissibility. And so when you encounter something like that, it favors a strict containment approach, extensive contact tracing, chase down, isolate every case until the virus is eventually wiped out, which we did. As for COVID, which is the blue dot, you'll notice there's a blue dot near the red dot connoting SARS called COVID-19 wild type. That's the initial COVID-19. When it first appeared, the wild type strain is slightly southwest from SARS. That is why in the early phases of the pandemic, we treated it like SARS and adopted a zero COVID-19 policy. But over time, COVID-19 mutated. As it mutated, became Delta, became Omicron, BA1. Now we got XBB 1.5, 1.9. They are constantly moving to the right, meaning they are more transmissible. But with vaccination, we don't just let them move to the right, we also make them move down and suppress the severity of these strains. So you see the blue dots now moving down closer to the green dot where influenza is. So overall, with vaccinations, later variants are closer to where influenza is on the vertical axis, which is why we are then able to open up and move towards living with the virus. So using this framework, what happens when a new pathogen of concern emerges in future? We may have to respond quickly with appropriate border and domestic SMM measures to minimize infections and to buy time. Then, with good science and the local and global capabilities I just described, we hope to quickly ascertain key characteristics of the pathogen, where it lies on the graph, and then determine the right responses. Concerted efforts to develop and secure effective vaccines and therapeutics will proceed in parallel. Third area of improvement, which is MOH will restructure to strengthen our organization. This is something we also did in the wake of SARS outbreak in 2003. MOH put in place a pandemic preparedness plan involving the primary care sector, which evolved into today's PHPCs, or Public Health Preparedness Clinic Scheme. Polyclinics and PHPCs served as our first line of defense to test and treat COVID-19 cases. They support home recovery. They also administered vaccinations and helped in surveillance efforts. So contrary to what Mr. Leon Pereira said, our family doctors actually, they have been and will continue to make an immense contribution during the pandemic and for healthcare in the future. We set up the NPHL, the National Public Health Laboratory. It conducts laboratory surveillance of infectious diseases and AIDS in outbreak investigations. When COVID-19 first emerged in Wuhan, it was the scientists from NPHL who designed the PCR test for COVID-19, 2 days after the scientists in China shared the genome sequencing with the world. We established the NCID, National Center for Infectious Diseases, which opened its facilities in 2019. And it provides high standard of infectious disease clinical management. These organizational enhancements after SARS built up capabilities that helped us respond to COVID-19. Given what we have learned from COVID-19 pandemic, we should once again review our organization structure to better prepare ourselves for the next pandemic. The one big lesson this time is that we need to rely on the wide repertoire of responses. As I explained in the charts earlier, each pathogen has unique characteristics, needing different responses. In fact, COVID-19 shifted around the charts, requiring us to change playbooks along the way. Specifically, for a severe but less transmissible disease like SARS, we need an individual-centric approach, comprising testing, isolation, tracing, quarantining, that is precise, accurate, and as error-free as possible. But for less severe but highly transmissible pathogens like Delta or Omicron variant, it becomes almost impossible to contact, trace, and isolate, especially as the disease increases and spread exponentially. It is also of no use insisting on gold standard accuracy and precision. Instead, we need to manage the exponential growth of infected persons through population-wide interventions. Mask wearing, ART tests in the community, self-tests, quarantine those, self-quarantine for those who are exposed, home recovery for those with milder symptoms. The individual-centric clinical approach versus the population-based public health approach, they are actually not mutually exclusive. In fact, they complement one another, and we adopted both during different phases of COVID-19 pandemic. We should institutionalize both sets of capabilities for the long term and able to deploy both with flexibility and dexterity in future pandemics. To do so, we will set up a new Communicable Disease Agency, or CDA, under MOH. It will oversee disease preparedness, prevention and control, surveillance, risk assessment, and outbreak response. This new agency will consolidate the relevant public health functions that today reside in MOH, NCID, as well as the Health Promotion Board. The NPHL, the laboratory, is a critical national resource and will be transferred to the CDA. The CDA will maintain oversight of the clinical facilities in NCID. Many countries such as South Korea, UK, and US, they have similar setups. They too, after COVID-19 crisis, is also reviewing their organizational setup. In addition, MOH will separately retain a permanent crisis strategy and operations group in the ministry. We call it CSOG or CSOC. CSOC was established during the pandemic and grew steadily as the pandemic progressed. It is the machinery behind all the pandemic-related operations that we are familiar with. Contact tracing, home quarantine, conveyancing to isolation facilities, testing, vaccinations, home recovery. All this coordinated and implemented by CSOC in MOH. CSOC was staffed by officers from various ministries, contract staff, and also staff from industries affected by COVID-19. For example, we had quite a number of SIA pilots as well as cabin crew working in CSOC. Most of these staff have returned to their industries. As Ms. Polisan said, as it rebounded from 2% to 80%, we lost all of them, but yet we're sad to see them go, but we are happy that they are gone too, because they are going back to their industries. So the operations have scaled down greatly. Nevertheless, we will keep a permanent CSOC force to maintain surge readiness for a mid-sized outbreak, as well as other health emergencies. And this includes preparing healthcare institutions to be crisis ready. In peacetime, when there's no emergency, they help us operationalize Healthier SG. As the skill sets turn out to be fairly similar, because it's not surprising because they are both public health focused. In addition, we will set up a healthcare reserve force made up of ex-healthcare workers and volunteers. We will train and equip them to reinforce our operations during larger surges, and they will complement the existing pool of SG Healthcare Corps volunteers. Finally, we will change the title of the DMS. Instead of Director of Medical Services, he will be called Director General of Health. which more accurately describes his role as the main overseer of both clinical and public health of Singaporeans. This will take place after the changes to the Healthcare Services Act come into effect later this year. This House has already approved the changes. With these changes, MOH will be organized to place greater emphasis on both clinical services and public health. They require different instincts, considerations, capabilities, and skill sets. Both are important and critical and will be institutionalized and built up within MOH. Let me now address a question that relates to public health measures, specifically on the issue of masking. Mr. Gerald Gian suggested the government was not forthright with the people, or that's what I heard, that during the initial stages of the pandemic, we did not impose mask requirements, not because of public health reasons, but because we did not have enough mask supplies. This is incorrect. In the initial stages of the pandemic, there was no clear understanding of the characteristics of the COVID-19 virus. We therefore align our policy to WHO's recommendations. And WHO, even up to March 2020, maintained that, and I quote, "A medical mask is not required for people who are not sick, as there is no evidence of its usefulness in protecting them." Unquote. The risk of shortage of masks for healthcare workers will put their lives in danger because they are in the front line. Is it a serious concern? It was. But it was not the basis of the prevailing public policy on masking. We aligned our policy with WHO. We reviewed and changed our masking policy in April 2020. That was also when WHO changed its guidelines, once the evidence on how the virus spreads became clearer. Particularly, there was now clear evidence that there was asymptomatic transmission via aerosol. Nevertheless, as acknowledged in the white paper, the whole issue of masking is one area where our decisions could have been better. But no question that during this period, government was totally forthright with the people and told the people what we knew. The fourth area of improvement is to update our laws. The Infectious Diseases Act, or IDA, is the principal legislation for the prevention and control of infectious diseases. It empowers MOH to take various public health actions for disease outbreaks, such as contact tracing, isolation of infected persons, testing of contacts, or the disinfection of premises, etc. The IDA also provides for the Minister for Health to declare a public health emergency in very grave public health situations, and that will activate extensive powers for the Minister, such as controlling the movements and gatherings of people and imposing curfews. While COVID-19 was a crisis and a serious threat, we did not declare a public health emergency. We wanted to restrict group sizes, but not to control movements of people. We were not planning to impose curfews or invoke the Requisition of Resources Act to marshal resources. In other words, the emergency powers under the IDA were too blunt and heavy compared to the public health measures and SMMs we needed at that time. So instead, Parliament enacted Part 7 of the COVID-19 Temporary Measures Act, or CTMA, to provide us temporary complementary powers to the IDA. This ad hoc legislation allowed us to deploy a broad range of tools to tackle COVID-19 at multiple layers without declaring a public health emergency. And this House just extended Part 7 of the CTMA for another year. Ideally, we should review and amend the IDA. As it stands now, the IDA envisages only two worlds of public health, peacetime or public health emergency, with no gradations in between. COVID-19 taught us that in a prolonged pandemic, we can go through different phases. So the IDA must be amended to deal with a wider range of scenarios. It needs to be more future-proof. Once the amendments are tabled, and if passed by the House, we can and we intend to rescind Part 7 of the CTMA. We will put forth the full proposal to the House later this year, but just to share some preliminary thinking, we envisage 4 public health situational tiers under the amended IDA. First tier is baseline, which is a peacetime state. Second tier, outbreak management, where a pathogen of concern is detected and measures may need to be implemented urgently to manage disease outbreaks. And these include contact tracing and quarantine, testing, border controls, and masking. And these will buy us time to understand the characteristics of the pathogens, the 6 characteristics I mentioned. Third tier is public health threat, where more stringent, widespread, and longer-term control measures and restrictions are needed. These include various SMMs and restrictions up to and including a circuit breaker-like imposition. And then finally, the highest tier, public health emergency, where very stringent measures such as curfews or requisition of public health assets and manpower may be effected. When these changes come into effect, we can also use these 4 situational tiers to replace the current DOSCON color coding. I think it is more intuitive to tell the public that there is an outbreak, a threat, or an emergency, as opposed to colors. And the law spells out what measures could take place under each situational state. Will this therefore prevent panic buying that we saw during COVID-19 when we changed DOSCON to yellow and orange? Some are already shaking your head. Indeed, not on its own. You just change color to descriptors. There's no reason why panic will just disappear. Whether a people panic during a crisis depends a lot on the information they are getting and whether they know what to do to protect themselves and then contribute towards societal resilience. If people listen to rumors, they do not know what to do, then most likely they will rush to supermarkets and stock up on toilet paper and instant noodles, and Mr. Seah Kian Peng will have a problem again.
Order. Leader.
Mr. Speaker, may I seek your consent and the general assent of members present to move that on the proceedings on the item under discussion be exempted from the provisions of Standing Order number 48.8, to remove the time limit in respect of Minister Ong Ye Kung's speech, and I suppose for good measure, Minister Gan Kim Yong's as well.
Give my consent as a leader of the House, have the general assent of honourable members present to so move. Aye. Leader, please proceed.
Mr. Speaker, I beg to move that the proceedings on the item under discussion be exempted from the provisions of Standing Order number 48.8 in respect of Minister Ong Ye Kung's and Minister Gan Kim Yong's speeches.
The question is as moved by the Leader of the House. As many as are of the opinion say aye. To the contrary, say no. I think the ayes have it. The ayes have it. Minister Ong.
Thank you. I believe that with the experience of SARS, H1N1, and now COVID-19, the government knows much better what measures are necessary and appropriate, and the people of Singapore understand much better what to do during a pandemic crisis. With that, there's a lower chance of having a panic. Fifth area of improvement. We need to ensure that we have early access to efficacious vaccines for future pandemics. Without sufficient doses of vaccines, our mass vaccination strategy would have been a non-starter. So what if we are willing to take the vaccines if there's no supplies? But securing vaccines is an art in itself, at best, an inexact science. This is where judgment I spoke about at the start of the speech made all the difference. How the vaccine procurement decisions were made in the early stages of the pandemic is an important story to be told in this House. and shall do it today. Spoiler alert, this story has a happy ending, as noted by Mr. Liang Yinghua. Despite our small size, and despite the worldwide shortage, Singapore was the first country in Asia to obtain COVID-19 vaccines, enough for all our people. But we also paid a price. So here's what happened. During the early phase of the pandemic, we set up an interagency work group chaired by the head of civil service and comprising senior officials from agencies, PMO, MOH, A-STAR, EDB, HSA, to develop our vaccine procurement approach. Once they were formed, they immediately faced two challenges. First, COVID-19 was a new virus. Although several vaccines were concurrently being developed at that time, nobody knew which one would work, so which one to buy. Second, every country was clamoring for vaccines, and there was limited manufacturing capability to meet that demand. As a small market, we lack negotiating power, always been so. And this would normally push us down the priority queue for delivery. The situation was worsened by supply chain disruptions caused by the pandemic. But time was of essence. So how to secure assured and early deliveries of vaccines? So on the first question of what to buy, the work group recommended a portfolio approach. Don't put all our bets on one vaccine, but buy a selected number of vaccines across different technological platforms. And this includes both mRNA and non-mRNA vaccines. To identify the most promising candidates, the work group was advised by a panel of experts from the research institutes, hospitals, and industry. And since we did not know which vaccine candidate would work, and we had to buy several types, and if one don't work, we must make sure the other one have enough volumes to cover our population. So therefore, we need to over-procure, such that the combined volumes of all the vaccine candidates more than cover the population of Singapore. On the question of how to secure assured and early delivery, we leveraged our relationships with the pharmaceutical companies and entered into advanced purchase agreements with fixed delivery schedules and quantities. And that made them bite, and we entered into the agreements. Then, to ensure quality and safety, all selected vaccine candidates were reviewed by the HSA thoroughly before being authorized for emergency use in Singapore. Then the Expert Committee on COVID-19 Vaccination, the EC19V, provided a second layer of independent review and gave recommendations on how to optimize the use of the vaccines. Then the first batch of Pfizer-BioNTech vaccines arrived in late 2020, Singapore being the first country in Asia to receive them. We rolled out the national vaccination program shortly after, from December 2020. Again, one of the first few countries in the world to do so, I think only after UK, US, and maybe Israel. The Moderna vaccine was added to the national vaccination program in March 2021, and Sinovac and Novavax in October 2021 and February 2022, respectively. While the mRNA vaccines were found to be highly effective in protecting against severe COVID-19 infections, around the middle of 2021, we faced two new concerns. First, there were early indications that vaccine protection could wane over time, especially amongst the elderly, so boosters will be needed. We therefore procured additional vaccine doses to administer boosters to the whole population. Second concern came up. New COVID-19 variants were emerging. There was a real possibility that one or more might break through vaccine protection and cause major new infection waves, causing many deaths or many cases of severe illnesses. Moderna and Pfizer-BioNTech therefore developed the new bivalent vaccines that provide better coverage against the newer virus strains. in September 2022, we took the decision to make a clean switch to these new bivalent vaccines. The monovalent one had to be stored away. Looking back today, if we can go back in time, and given the uncertainties, the high stakes, what we knew, what we did not know, and the challenges we face, I think we would have done things the same way. Because we secured safe and efficacious vaccines, delivered when we needed them most, Singaporeans took them with confidence, even with relief. I was relieved. When it arrived, I can take the vaccine. And we are one of the first in the world. We built up our population immunity and then achieved TOSCON Green today. But there is a price to be paid because we deliberately over-procured to mitigate the uncertainty of selected vaccine candidate not working and the possibility of supply chain being disrupted. There would be spare vaccine stock, which will expire. Some months ago, MOH was asked by the media how much of our vaccines had expired. We could only reply that about 10% of our stock had expired because of confidentiality agreements that we have entered into with the drug suppliers, the vaccine suppliers. I would have preferred to be more transparent and forthcoming with the information. We have since discussed with the vaccine suppliers, and they have agreed. We can reveal the total value of the expired vaccines so long as we do not give further breakdowns of quantity that enable people to guesstimate or estimate the cost of each dose, which is what they are sensitive about. So these are the numbers. To date, expired vaccines are about 15% of the doses we ordered, with a total value of Sing dollars 140 million. In the coming months, this is likely to rise to close to 25% as more vaccines expire. After that, it should stabilize. We had tried to donate our spare vaccines, but there have been no takers because there has been an oversupply of vaccines in the world. Manufacturers have ramped up their production capacity and demand has been going down as pandemic stabilizes. There are reports estimating that expired vaccines globally could range up to 500 million doses or more. The expiry of unused vaccines was an insurance premium, the price we were prepared to pay to stave off the risk of catastrophic consequences. What are these consequences? Let me illustrate. Before vaccines were available, we had to resort to a circuit breaker in April 2020 to contain the pandemic. The 2-month circuit breaker cost us about $11 billion in terms of GDP loss. And we spent close to another $60 billion over 2 financial years to cushion the hardship for businesses and workers, and not to mention all the heartaches and difficulties families had to go through. Without vaccines, we would certainly have to resort to further circuit breakers during the Delta and Omicron waves in late 2021 and then throughout 2022. But we did not have to because the vaccines, we got them early and they protected us. More importantly, our approach averted many deaths due to COVID-19 infections and protected Singaporeans against that catastrophic consequence. Let me now address a few questions regarding vaccines posed by members yesterday. Ms. Hazel Phua thought that MOH favored mRNA over other non-mRNA vaccines in our regulatory approval. Actually, she has mistaken. Several non-mRNA vaccines could not secure HSA's approval because of insufficient data on safety and efficacy, and we cannot compromise on our standards. Ms. Hazel Phua and Mr. Yip Hon Wing also asked if VDS measures were too harsh on the unvaccinated. In a pandemic, measures can be harsh. The circuit breaker is harsh on everyone. The relevant question is whether, from a public health perspective, the measures are necessary and justified. So we need to be mindful while everyone should make their own medical choices, in a pandemic, individual actions affect not just yourself, but also others around you. When the vast majority chose to take the vaccine, they not only protected themselves, but also their loved ones, and they raised our collective resilience. As for those who did not take the vaccine, they do not just put themselves in danger and at risk, but they also put others around them, including their colleagues at their workplaces, at risk. Hence, VDS was needed as a public health measure. But we understand the hardship some of them have to go through. Some of them are allergic to the vaccine. Therefore, the moment we can step down VDS, we did so. More importantly, we must continue to be prepared in case of a dangerous variant of concern emerges. So this is our vaccine strategy going into the future. First, MOH will maintain and periodically refresh an adequate stock of COVID-19 vaccines to allow continued protection of the elderly and vulnerable as needed, and to facilitate a rapid response should there be a major or more severe pandemic wave. Second, we will maintain a network of vaccination centers, primary care clinics, polyclinics, and a baseline footprint of 5 to 10 joint testing and vaccination centers, even during DORSCON Green. With this, we will be able to administer a booster to all persons aged 50 and above and the medically vulnerable within 3 weeks, if necessary. Third, we are negotiating agreements to secure early access to vaccines against other pathogens with pandemic potential. These might include new influenza and other respiratory viruses. Fourth, we will invest in vaccine research and development, like the PREPARE program I spoke about earlier. One of our objectives is to establish how to quickly develop a working vaccine based on either the mRNA or protein subunit platform and bring it to clinical trials locally. Fifth, through the EDB's effort, we will be anchoring 6 vaccine manufacturing plants in Singapore. So in response to Dr. Tan Wu Ming, EDB will continue to engage other vaccine manufacturers to invest in Singapore, grow our biomedical sector capabilities, and cement our position as a pharmaceutical hub of Asia. And finally, we will continue to do our part to strengthen global health security and support fair and equitable access to vaccines. There is now a global effort to develop a safe, effective vaccines within 100 days of a public health emergency of international concern being declared. And MOH, we are actively contributing to that effort. Mr. Speaker, sir, I will conclude with the last lesson. And that is to recognize that a crisis forces us to do or try new things. What we thought was not possible to do or would have taken years to implement were accomplished in a matter of months because we were pushed by the crisis. We were stretched, and when it's released, we will not rebound back to the old equilibrium. We will reach a new equilibrium. So for example, today, we are in a new era of flexible work arrangements. Our schools built up strong digital capabilities, and all secondary school students today, they have their own learning devices because of COVID-19. I'm sure Changi Airport will rebound to a new level of capability post-crisis. And in healthcare, the changes are even more profound. During the crisis, public and private healthcare providers became connected by the same IT network. Everyone downloaded and got familiarized with healthcare apps. And as pointed out by Ms. Ng Ling Ling, telehealth became the norm. We became converts of preventive care as we became conscious of hygiene, got used to diagnostic tests, wearing masks, and vaccinated routinely. This is really what sparked Healthier SG. It is a strategy born out of crisis and will profoundly change the landscape for healthcare in Singapore. The chapter on COVID-19 is a thick one. in the story of Singapore, one with high drama, dark days, personal tragedy, as well as bright spots and many high points of courage, collective will, and resourcefulness. The story featured so many men and women who fought to keep Singapore safe. I cannot name everyone, but they are reflected today in the stories of some of their brethren. Dr. Tan Chi Kiat at Ng Teng Fong Hospital, who was part of the team to develop a negative pressure isolation chamber used to intubate infectious COVID-19 patients and help keep her team safe during dangerous procedures. Dr. Anita Anature, who personally oversaw the setup of medical operations at the S11 dorm and helped calm and assure the migrant workers there that they would be taken care of. Mr. Salman Imtiaz, a volunteer with the SG Healthcare Corps, who took a leave of absence from his university studies to help as a vaccinator with Raffles Medical Group. Ms. Christine Joy Cordovilla Solacito, senior staff nurse at SGH, who used her experience with MERS and Ebola to handle early COVID-19 positive patients from Wuhan. And she cared for ICU patients. She administered chemotherapy in the isolation ward, and she delivered babies for COVID-positive pregnant mothers. Dr. Wong Jia-yi from MinMed Group, who became a father 3 times over during the pandemic. One pair is a twin. But he stayed his post, leading vaccination centers, a regional swab center, mobile vaccination teams, and home recovery operations. Captain Lee Jia-wei, who volunteered to care for migrant workers being isolated at Singapore Expo and to protect his family, did not go home for 60 days and stayed at Changi Expo. Ms. Sandra Goh, a lead stewardess with Singapore Airlines, who was furloughed when borders closed, switched to become a care ambassador at a hospital, and now she's a manager at the specialist outpatient clinics at KTPH. She told me she could transfer her skills from cabin to ward. Mr. Mahmud bin Mohammed Yahya and Mr. Humam Sufi bin Mohammed Ali, they are a driver-medic pair from Ambulance Medical Services Private Limited, who at the height of the pandemic, they worked 14-hour days for several weeks, making up to 16 trips a day to ferry patients to and fro COVID-19 care facilities. Mr. To Guan Lu, one of my community volunteers, who between ITE and Polytechnic requested to work for MOH, to work for CSOC and handle home recovery cases. And when he discovered that he did not qualify for the COVID Resilience Medal because his stint was slightly short, he said it's okay. I'm just proud that I was able to help. I sincerely thank all of them and the hundreds of thousands who contributed. We write the story to record suffering and sacrifice, but also strength and remarkable commitment on the part of so many to successfully overcome the crisis. We write to remember, but also to learn. If we do, then in the next chapter, our hospitals and healthcare systems will be better, our laws more complete, our vaccines and medical supplies more secure. And so we write our next chapter, not knowing whether the world will dawn bright or dark, hostile or friendly, but confident in ourselves that Singapore has become stronger through this crisis and we can stand taller to meet the next one. Thank you, sir.